Ehlers Danlos Syndrome is a connective tissue disorder, and it has various manifestations and various types, and that can make it difficult to diagnose. This is a group of genetic, phenotypically heterogeneous disorders, and in most cases, the patient will appear normal at birth, but then they go on to develop various symptoms, and the symptom constellation set that they're going to develop is really going to depend on what type of EDS that they have. We primarily associate Ehlers-Danlos syndrome with skin hyperelasticity, as you see in this gentleman on this picture here. Also joint hypermobility, fragility of the skin and blood vessels, and delayed wound healing. And on the test, I would expect that you're going to be asked about the stereotypic Ehlers-Danlos syndrome, which we call classic Ehlers-Danlos syndrome, but there are other types, and I want you to be aware of a couple of those. There are 6 types of Ehlers-Danlos syndrome, but really only 3 of them are commonly seen in clinical practice. Only about 100 cases of the other 3 types have been reported. So let's just talk about connective tissue, just so we know what we're really referring to here. There's 4 major types of tissue in the body: epithelial, muscle, nervous, and connective tissue. Epithelial tissue primarily serves to protect. It also absorbs substances. It filtrates, particularly in the kidneys. And when it's in the form of glands, it secretes substances. Muscular tissue includes skeletal, cardiac, and smooth. They share in common that they have contractile strength. They have the ability to shorten and exert force. Nervous tissue obviously receives stimuli and conducts electrical signals to and from the CNS. And then connective tissue, which we're going to talk about here, and which is important when we're talking about EDS, is the most abundant tissue in the body, and it serves to support, connect, and separate other tissues from one another, and it fills space in between organs. So there are 3 components of connective tissue: ground substance, which is a clear and colorless viscous fluid which contains glycosaminoglycans and proteoglycans, which help fix the fibers in place. It also includes cells, which can be fibroblasts, fibrocytes, reticular cells, tendon cells, fat cells, and melanocytes. And then it can contain various fibers, which include collagenous fibers, which we refer to as collagen. And there are several types of collagen. These are found in tendon, ligament, bone, skin, blood vessels, cartilage, the gut, and in intervertebral discs. And then there's also reticular fibers, which is made up of type 3 collagen, which is then cross-linked to form reticulin. This is found particularly in blood vessels, as well as the lymphatics and the liver. And then finally, elastic fibers, which is made up of elastin and then various other components, such as fibrillin and glycoproteins. So just bear with me here. I'm coming off of a cold, so if I'm coughing, forgive me. So there are several types of collagen, 29 in total, but the first 5 are the ones that are perhaps the most abundant. So type 1 is the most abundant overall. This is a dense and strong connective tissue. It's present in tendons, bone, ligament, skin, arterial walls, organ capsules, surrounding the teeth, cornea, as well as inside muscle and fibrocartilage. And where do we see that fibrocartilage? That's the cartilage that makes up the pubic symphysis, the discs, the menisci, temporomandibular joint, and so forth. There are 2 genes that code for the 2 subunits of type 1 collagen, called COL1A1 and COL1A2, and those are responsible for producing the alpha-1 and alpha-2 subunits. Type 2 collagen is a looser collagen. It's the basis for hyaline cartilage and articular cartilage. And that's what your nose and ear are made out of. Type 3 collagen is also loose. It's the basis for reticular fibers. This is present in the skin, lungs, and vascular system. It's also seen in bone, tendons, cartilage, uterus, kidney, dentin, and bone marrow stroma. And then there's a gene called collagen 3A1, COL3A1, which codes for the subunit protein of type 3 collagen. And then type 4 collagen is primarily found in the basal lamina, which is the layer of tissue that supports epithelium, sort of like the basement membrane for the epithelium. In particular, type 4 collagen is found in the glomerular basement membrane in the nephron, as well as the pulmonary basement membrane and the basilar membrane inside the inner ear, and then the lens. And there's 6 subunits for type 4 collagen, 6 genes that code for type 4 collagen, and they are COL4A1 through 6. Type 5 collagen is found particularly in fetal membranes and also found in most places where type 1 collagen is found. Okay, so I think that's all I wanted to talk about as far as collagen. And just to add here, blood and lymph are also considered components of connective tissue, but they don't contain fibers. They contain plasma, which could be considered equivalent to ground substance, and they also contain cells, but they don't contain the fibers. Now, there are several types of Ehlers Danlos syndrome, and they used to be classified as type 1, type 2, type 3, all the way through type 7. However, now we have renamed the system, and so there are 3 really major types of Ehlers Danlos syndrome, which I would expect on the test you'll be asked about. If you're given a vignette, you'll be asked about the classic Ehlers Danlos syndrome, and this used to be called type 1 and type 2. And this is associated with a premature birth, secondary to premature rupture of membranes, skin hyperelasticity, fragility, easy bruising, generalized joint hypermobility, and poor wound healing. Those are the symptoms we typically associate with Ehlers Danlos syndrome, and this is what we see in the classic form. This is associated with mutations to type 5 collagen and type 1 collagen. It has an incidence of 1 in 20 to 50,000, and this is inherited in an autosomal dominant pattern. Hypermobile Ehlers Danlos syndrome is formerly the type 3 Ehlers Danlos, and this is characterized by significant joint hypermobility as well as chronic pain, and it's often misdiagnosed as fibromyalgia. You'll also see frequent subluxation and dislocation of joints. This has been associated with mutations of tenascin and type 3 collagen, but there's probably other genes involved, and really these are just based off of case reports. And so you're going to see that genetic testing doesn't really play a big role in the diagnosis of Ehlers Danlos syndrome. For this reason, we don't really have a very clear genetic understanding as far as what particular genes are involved. The incidence is 1 in 10 to 15,000, making this the most common type of Ehlers Danlos syndrome, and it's generally accepted that this is an underdiagnosed disease, and so the incidence is probably more common than these numbers suggest. Vascular Ehlers Danlos syndrome is an important differential because this confers a different prognosis. This is formerly called Ehlers Danlos type 4, and this is characterized by a pronounced dermal thinning with a very visible underlying venous network, acrogeria, which is sort of an aged appearance of the hands. And importantly, the vessels are fragile and they're prone to aneurysm and rupture. This is also associated with hollow viscous rupture, particularly including the uterus and the bowel. And this is associated with less skin hyperextensibility and joint hypermobility than in the other forms. And this is highly associated with mutation to COL3A1. The incidence is about 1 in 100 to 200,000, and this is also an autosomal dominant inheritance. There's a few other forms of Ehlers Danlos syndrome: kyphoscoliosis, EDS, arthrochalasia, EDS, dermatosparaxis, EDS. These are very, very rare. Only about 100 of these cases total have been described, so I wouldn't worry about these for the test. As far as the manifestations, so I kind of described those, but particularly in the classic EDS is where you're going to see those classic signs that you probably learned in medical school that are associated with EDS: the joint hypermobility, dislocations, hyperelasticity, atrophic scars, poor wound healing. Then in the hypermobile EDS, you're really going to see hypermobility and dislocations, but you're also going to see musculoskeletal pain. That's highly associated with EDS. For the most part, hypermobile EDS is where you'll see more joint hypermobility than the classic EDS, but you also see musculoskeletal pain as well. And then the vascular EDS is a little bit different than the other forms, in which there's a significant risk for aneurysms, aortic root dilatation, and organ rupture. So here's an example of joint hypermobility. I got this from the American College of Rheumatology. In this patient, they're able to oppose their thumb to the volar forearm. Even though this is passive, this is one of the Brighton criteria, Beighton criteria of EDS. So this is a sign you're going to look for. I'll show you what the Beighton criteria are in a little bit. So here's a 90-degree extension at the 5th metacarpophalangeal joint, and this is another sign of EDS. So here you have hyperextension at the elbow. And this is obviously abnormal. You shouldn't be able to extend your elbow like this. And then also note the bruising. Remember that these patients are at risk for bruising. Here is more than 10% hyperextension of the knee. And then this patient is able to put their hands flat on the floor without bending the knees. That's just showing a little bit of extra hypermobility. So here's another hyperextension at the elbow. So you can probably see these patients are often the ones that are called by lay people as double jointed. Skin hyperelasticity is another thing you'll see in type 1 and 2, classic and hypermobility EDS. And then here's the skin translucency. This is typically seen in the vascular EDS. So note that you can see the veins beneath the skin. And in most people, you'll be able to see some veins underneath the skin, but this is obviously not a place where you typically see veins beneath the skin. This is on the chest. This is acrogeria, more of an aged appearance to the hands. You can see some, in some cases you'll see bluish sclera. So you'll also see bluish sclera in conjunction with osteogenesis imperfecta, and that's because of the type 1 collagen defect. A lot of people can do this, so this doesn't necessarily mean EDS, but this is called Gorlin sign, and that's the ability to touch the tongue to the nose. Some people have longer tongues, and so they're able to do that, but about 50% of patients with EDS will be able to touch their tongue to the nose. The scarring pattern is a little bit different in EDS. They tend to have atrophic scars or also very elaborate scarring. This is an atrophic scar. It's also referred to as a cigarette paper scar. And you can also see this sort of skin appearance in patients, particularly on their knees, but in this patient you can see it on her forehead. So remember the easy bruisability. And then, okay, so this would be vascular EDS, type 4. It can have a facies to it, so they can have small earlobes. Also, they tend to have a very narrow, thin upper lip and a small chin. And so you can kind of see that in these patients. And these are all patients with vascular EDS. As far as development, pretty much we're only going to be seeing abnormalities in their physical development. EDS doesn't have any implications cognitively or socially. In young children, they tend to have hypotonia, and so that can delay their gross motor milestones, such as sitting up unsupported, walking, crawling. Joint hypermobility is usually apparent by early childhood. Once they do get up and walk and crawl, then they can start to form bruises. When kids start to walk, they tend to fall too, and so you'll notice easy bruising in a lot of these cases. Serious injuries can become evident, particularly in vascular EDS, but you can notice more serious injuries if the child is undiagnosed and they're participating in contact sports like football or soccer or basketball. For diagnosis, this is typically a very elusive diagnosis, and it's made clinically when you have suspicion. Genetic testing can be done because we do know some of the genes that play a role, but primarily genetic testing is a secondary role. The Beighton criteria is a criteria used for joint hypermobility syndrome, which a lot of physicians consider synonymous with the hypermobility EDS. I should say this is so the Beighton criteria. If you have greater than greater than 4 out of 9, that's consistent with JHS. So greater than 4 out of 9. I mistyped that there. So the Beighton criteria is met when a patient fits 4 out of 9 points, and this is you get 1 point for each side. You can dorsiflex the 5th metacarpal to 90 degrees or greater. 1 point for each side. You can oppose the thumb to the volar aspect of the forearm, and that's again 1 point per side. If you can hyperextend the elbow to 10 degrees or greater, that's 1 point per side. Hyperextend the knee to 10 degrees or greater, that's 1 point per side. And then if you can place the hands flat on the floor with the knees fully extended, that's 1 point. So I showed you all those pictures of what that looks like. So the total, maximum total is 9. Greater than 4 out of 9 is consistent with joint hypermobility syndrome. Not necessarily Ehlers Danlos syndrome, because you have to, in many cases, show some of those other symptoms, such as skin hyperelasticity or some of the features that you see in vascular EDS. Now we have the Brighton criteria for diagnosing EDS or making a tentative diagnosis of EDS. So note the similarity in name. So you have the Beighton score for EDS and the Brighton criteria for EDS. So the Brighton criteria for EDS is satisfied if there are 2 major criteria that are met, or if there is 1 major criteria with 2 minor criteria, or if there's 4 minor criteria, or if you have an affected first-degree relative in addition to 2 minor criteria. So in other words, you could really consider having an affected first-degree relative to be a major criteria, since if you have that plus 2 minor criteria, then you have a tentative EDS diagnosis. So the major criteria are a Beighton score of more than 4 out of 9 at any point, which should be consistent with JHS. Arthralgia for more than 3 months in 4 or more joints. And then, like I said, this isn't technically considered a major criteria under the Brighton criteria, but it fits mathematically because if you have an unaffected first-degree relative plus 2 minor criteria, that satisfies the Brighton criteria. The minor criteria include a Beighton score of greater than 1 out of 9 at any point, arthralgia of 1 to 3 joints, or back pain, spondylosis, spondylolysis, or spondylolisthesis. Dislocation in more than 1 joint or in 1 joint more than once, and particularly we're talking about the hips, knees, and shoulders. 3 or more soft tissue lesions, a marfanoid habitus, which is a tall patient with a long arm span, an upper segment to lower segment ratio of less than 0.89, and then arachnodactyly. Striae, hyperextensible skin, thin skin, abnormal scarring. Ocular features such as droopy lids, myopia, an anti-mongoloid slant, varicose veins, hernia, uterine or rectal prolapse, and mitral valve prolapse. So the Brighton criteria is primarily applied to adults. It has not been validated in children less than 16 years of age, but that doesn't mean it's not used in some cases. Don't memorize the Brighton criteria for the USMLE. You won't be asked on that specifically, but it's worth knowing that these are the things that we look for. So the Brighton score and the Brighton criteria are used together to diagnose Ehlers Danlos syndrome clinically. The differential for EDS includes cutis laxa. So cutis laxa is sort of where you have the sagging skin, which can look like hyperextensible skin, but in cutis laxa, the skin is just saggy. It's hyperextensible, but the difference is in EDS, the skin maintains its elasticity. So when you pull the skin down in EDS, let's go back to that picture. Way back. Okay, so here, if you were to pull this skin away, in cutis laxa, the skin would just hang. Okay, but in EDS, you pull this skin away and it's going to snap right back into normal position. So the elasticity of the skin is it's hyperelastic skin, but it will retain its elasticity when it's released. So it's not lax skin, it's just hyperelastic. All right, here we go. Okay, Marfan syndrome shares some similarities to vascular EDS in that there's aortic dissection, vascular complications, but Marfan syndrome is more associated with that characteristic habitus, the arachnodactyly, whereas Ehlers Danlos syndrome is more associated with joint laxity and skin hyperextensibility, which we don't necessarily see in Marfan syndrome. And it's always helpful to refer to the family history when making your differential. So you see easy bruising in Ehlers Danlos syndrome, and that can also be seen in some bleeding disorders, particularly platelet disorders, either qualitative or quantitative platelet disorders. Coagulation and platelet counts should be normal, but in some cases of EDS, you can have prolonged bleeding time. And patients with severe bleeding disorders who do have prolonged bleeding time, or even some who don't, they have used desmopressin to try to increase the factor count. Vitamin C deficiency, remember vitamin C plays a role in collagen synthesis and maturation, and so that should always be considered, particularly in children. You just get a dietary history. Fibromyalgia is often confused with type 3 or the hyperextensible EDS, particularly because of the association with widespread pain and fatigue. That's going to be seen both in fibromyalgia and in hyperextensible EDS. So that can be a tricky differential. The two can get confused with each other. But with fibromyalgia, typically the other stigma of EDS are going to be absent. So the hyperextensible skin, the joint issues, and so forth. For management, this is really, there's nothing we can do other than prevent complications. So it's going to be a multidisciplinary approach, primarily going to be spearheaded by the rheumatologist, and we're going to prevent complications and address their symptoms. So initially, you'll refer them to a rheumatologist and a medical geneticist. If you suspect vascular EDS, they should also be referred to a cardiologist. We will manage their pain with medication as needed, NSAIDs, opiates have even been used. Physical therapy is useful for pain in some cases, but also for children to help them achieve motor milestones if it's diagnosed that early. Preventative management includes avoiding high contact activities to avoid bruising, but particularly in vascular EDS to prevent you can get really bad bleeding, particularly of the larger vessels. So we're talking more like renal arteries and iliac arteries, and so forth. In vascular EDS, pregnancy should be avoided because of the risk of uterine rupture. Sunscreen and mild soaps should be used to prevent premature aging of the skin. And then fall precautions at home, so making sure you don't have any loose cords, rugs, and so forth. In vascular EDS, a drug called celiprolol has been used, which is a beta-1 blocker, cardioselective, and this is used to reduce the risk of vascular events. Long-term, people with classic and hypermobile EDS typically have a normal life expectancy. They just have increased morbidity with their complications. Prognosis is somewhat poorer for vascular EDS. About 25% of these people will develop a major health problem by age 20. By age 40, 80% will develop a life-threatening complication. A lot of times this is going to be aortic dissection, significant internal bleeding, and the median life expectancy for vascular EDS is shortened. It's about 50 years of age.